I want to talk about non-STEMI, and I want to give a lot of ideas regarding troponin and EKGs beyond what you see in guidelines and books. First, you need to know the 4 big types of myocardial injury each time you see troponin elevation. How do we clinically define MI? So in order to call myocardial infarction, you need 3 conditions. 1, you need troponin elevation above injury cutoff, which is above 99th percentile. 2, you need evidence of overt clinical ischemia. So troponin elevation is not enough to define MI. It defines myocardial injury. It's necessary to define MI, but it's not enough. So you need troponin elevation and clinical evidence of acute ischemia by one of the following 3. Angina, EKG with dynamic ST abnormality or evolving Q waves, or the third one, echo abnormality, and specifically segmental wall motion abnormality, not global dysfunction, which is not specific. And the third condition, that troponin needs to have a rise or fall more than 20%, not a plateau steady state troponin. So once you meet all 3 of those, then you can define MI. And for the evidence of clinical ischemia, you only need one of those 3, angina, EKG, or echo. So once you meet those, you have myocardial infarction. Then once you have myocardial infarction, you classify it into type 1 or type 2 MI. So even for type 2 MI, it's not enough to have troponin elevation. You need to have angina or EKG, ST or Q, or segmental wall motion abnormality. Now, we classify MI into type 1 or type 2 based on clinical judgment and context. If you have a context of a major systemic illness such as shock, major infection, severe anemia, bleed, or even a major cardiac illness such as severe heart failure, severe hypertension, arrhythmia, you may consider that as a type 2 MI. It's an MI due to an acute demand supply mismatch. And type 2 MI is divided into type 2 MI with no underlying CAD or type 2 MI with underlying stable CAD. The injury will be bigger, evidently, if you have type 2 MI with underlying CAD, and the long-term prognosis will be worse. Now, if the context suggests that the patient is presenting primarily with chest pain and no major other acute non-cardiac or cardiac illness, this is what we call type 1 MI, and this is what we call acute coronary syndrome. The term acute coronary syndrome means type 1 MI, which means acute plaque rupture and thrombosis. That's type 1 MI. And of course, there are non-STEMI and STEMI. The term non-STEMI should be reserved for type 1 MI, acute coronary syndrome. Type 2 MI, usually don't use that term type 2 non-STEMI. Use the term type 2 MI. Usually type 2 MI is without ST elevation, typically. Now, if you have a troponin elevation, but you don't have a clinical evidence of ischemia, this is what we call non-ischemic myocardial injury or non-MI troponin elevation. This is the most common cause of troponin elevation in the hospital. Now, the mechanism for non-MI troponin elevation is somewhat similar to type 2 MI, except the injury is not as severe. That's why you don't get angina or ST abnormality or wall motion abnormality on echo. So kind of similar mechanism, some systemic mechanism or cardiac mechanisms such as heart failure decompensation or severe hypertension or diastolic heart failure or fast arrhythmia, but it's not as severe of an injury. And it can be like type 2 MI with or without underlying CAD, although it's also more commonly without CAD because the injury is not very pronounced. And non-ischemic myocardial injury is divided into acute or chronic, depending whether we have a troponin rise and fall or not. So you can have troponin rise and fall in non-ischemic myocardial injury. It's just you don't have a clinical evidence of ischemia, none of those. And the chronic non-MI myocardial injury is usually seen in those patients with chronic illnesses, chronic severe anemia, chronic advanced CKD, chronic advanced heart failure, chronic cardiomyopathy. This classification is important because there is a graded worsening of cardiac prognosis the more you progress from non-ischemic myocardial injury to type 2 MI with CAD and type 1 MI. There is also progression in diagnostic markers. So how do you distinguish between those? Beside the clinical picture and the context, the more you have pronounced ST abnormality, angina, troponin, and echo, the more you're leaning toward type 2 MI with CAD or type 1 MI. Another important idea here, I want to elaborate slightly on it, is regarding angina and the EKG. I mean, what do we call angina? The best and most specific to call it ischemia is chest pain. Not so much dyspnea and heart failure, although in context, those may qualify as the clinical feature of MI. But the problem with heart failure and dyspnea is that they can be their own primary processes unrelated to ischemia. Regarding the EKG, I will detail it a little later, but what we consider ischemic EKG is dynamic ST depression, dynamic on serial EKG. That's what really suggests non-STEMI, not the static ST depression. Or evolving progressive Q waves, not the static Q waves. And not T inversion. T inversion in general, even if it's dynamic, it's not specific for ischemia unless it's the deep T inversion more than 5 millimeters that is evolving progressive on EKG, or the biphasic T inversion, particularly the biphasic T inversion in the precordial lead that looks like Wellens that I will show in a little bit. Now, why is this classification important? Because it changes management and prognosis. Ischemic workup is not needed or justified for this category, which is, again, the most common category we see in the hospital. Antithrombotic therapy is not justified for that non-MI myocardial injury either. I see heparin overly used in those patients. It shouldn't. Now, type 2 MI is a bit more tricky. It can be hard to distinguish type 2 MI with underlying CAD from type 1 MI. And there are cases where it's not clear whether diagnosis type 1 MI or type 2 MI with underlying CAD. And those cases, we tend to manage them like type 1 MI. And eventually, cardiac catheterization will help clarify. But generally speaking, when you classify the patient clinically as type 2 MI, even if you believe type 2 MI with underlying CAD, we don't use antithrombotic therapy for those patients, or at least antithrombotic therapy is not an established therapy for those patients because you have a stable CAD. If you have CAD, it's a stable CAD. It's not a thrombotic CAD. So no justification for antithrombotic therapy. And in terms of catheterization, we don't cath those patients acutely or systematically. So in type 2 MI, the primary therapy is directed toward the primary insult, whether sepsis, severe anemia, transfusion, hypertension, arrhythmia. Antithrombotic therapy and coronary angiography are not warranted acutely and systematically. Ischemic workup by means of non-invasive tests or coronary angiography may be electively performed, whether before or after discharge. And the decision to do ischemic workup and the timing of it and the type of it, coronary angiogram or not, depends on the severity of the ischemic finding and troponin rise versus the severity of the stressors. The more you have ST abnormality, angina, and troponin echo abnormality, the more you're leaning toward doing cardiac catheterization on those patients, but not necessarily in the first 24 hours after stabilizing their non-ischemic insult. And here are some illustration. Let's say you have a patient who has an uncomplicated pneumonia or an acute anemia of 8, not very severe. Yet he has a pronounced ST depression and troponin T over 300. He likely needs coronary angiography before discharge because he either has type 2 MI with underlying significant CAD or type 1 MI that was triggered by that non-cardiac insult, by the stress of the non-cardiac insult, plaque rupture related to that insult. Consider that patient, on the other hand. He has massive septic shock or profound anemia with mild transient ST depression and troponin of 100 to 200. Well, this patient, I'm less likely to do coronary angiogram, maybe less likely to do any ischemic workup on him. So type 2 MI with underlying CAD and type 1 MI may overlap. You individualize the severity of the markers versus the severity of the stressor to make decision. But generally speaking, antithrombotic is not justified. In a case maybe initially consider type 1 MI only to be later reconsider type 2 MI once evidence of acute non-cardiac illness arises, fever, bacteremia, or once coronary angiography shows no acute disease, or vice versa. Take this patient. He has a troponin of 400 in the setting of septic shock with transient ST depression. We initially considered it type 2 MI with likely underlying CAD because of the severity of the troponin rise and the ST depression. But cath shows acute thrombotic lesion. So in retrospect, we change our diagnosis to type 1 MI. So there is a fluidity in the diagnosis between type 1 MI and type 2 MI with underlying CAD. Now, important ideas regarding troponin. How can we use troponin to help us decide that progression and what's the real diagnosis? EKG can be very helpful depending on the presence of EKG abnormality and how pronounced they are. They make you lean toward this or at least that one, the EKG, but troponin can help as well. And I will show you my own classification of that. This is my own classification of troponin values for various myocardial injuries. And keep in mind, there are two types of high sensitivity troponin. There is the high sensitivity troponin T, which we have at our institution here, and there is the high sensitivity troponin I, which is used at the VA and at many other outside institutions. And always when you look at high sensitivity troponin, try to figure, is this troponin T or I? Because troponin I has a 3 to 10 times higher value than troponin T. And the higher the troponin and the bigger the injury, the bigger the discrepancy. It can become 10 times higher, the troponin I compared to troponin T at higher troponin values. And here are the cutoffs I use. For troponin T, the MI cutoff is that 14 to 22. 14 in women, 22 in men. Between 14, 22 and 100, this is a zone where it's frequently a non-MI myocardial injury. Between 100 and 300 plus, it's a zone where it's frequently type 2 MI with no CAD. Between 300 plus and 1,000, it's frequently type 2 MI with CAD or type 1 MI non-STEMI. Above 1,000, it's overwhelmingly type 1 MI, frequently even type 1 MI STEMI or STEMI equivalent, the so-called acute occlusion MI, OMI. Now, evidently, there's a lot of overlap between those zones. Particularly, the higher level diagnosis, type 1 MI, type 2 MI with CAD, may very well be seen at the low troponin value that are just above the MI cutoff. So you may very well have a type 1 MI here in that 14 to 100. In that zone, 14 to 100 of troponin, if you take all comers, type 1 MI is likely less than 50%, but 50% is a big number. So you may be type 1 MI depending on the context here, but it's frequently a non-MI injury. The key idea is that those lower level diagnoses, non-MI injury and type 2 MI with no CAD, usually don't cause the higher troponin levels, but the higher diagnosis can cause the lower troponin levels. And here you can add, for that injury zone, you can add other numbers. Instead of 100, 300, you can put 52, 100, which are used in some MI troponin algorithm. Those will be even more specific for an injury and less likely to be an MI, that 52, 100 cutoff instead of 100, 300. And those numbers, I obtained them from reviewing a lot of registries. These are some of the ones that I used to obtain the higher values. But here are some case illustration. We recently had a 65-year-old woman with chest pain and a troponin T of 35 that went up to 50. So she was in this zone here that could fit with non-MI injury. So 14 to 52 or 100 is a gray zone. More than 50% of cases are non-MI injury, but she has no explanation here. This is non-STEMI, and she has a delta of over 20%. So this is a non-STEMI. Unfortunately, she was discharged home, and she returned 2 days later with inferior STEMI. So use the context and the EKG, not just that zone. But this is very helpful classification in context. This is another patient, 70-year-old man. He has history of heart failure with the F 20%. He presents with severe heart failure, pulmonary edema, lowish blood pressure, and acute kidney injury. His troponin T is 400s. EKG shows LVH and static secondary ST depression, no Q wave. This patient, his troponin is here, but I believe he most likely has a non-MI myocardial injury with or without underlying CAD. I don't believe he has type 1 MI looking at the context. And there is a good chance that even though it is 400s, the troponin, he probably doesn't have underlying CAD because he has no Q waves. Lack of Q in severe cardiomyopathy suggests non-ischemic, although some proportion, up to 30%, could be ischemic. But anyway, this is not type 1 MI looking at the presentation. This is another patient, 72-year-old man, no prior cardiac history. He's had off and on chest pain that woke him up last night, then ongoing chest pain since this morning for the last 4 hours. His high sensitivity troponin is 44, mildly increased. This is his first EKG, unremarkable. But then the second EKG, 30 minutes later, again, this patient has ongoing chest pain, so we need to keep repeating EKG every 10 to 30 minutes. So 30 minutes later, that EKG shows an abnormality that out of this context could be non-specific. He has biphasic T in V3 and mild T inversion in V4 through V6. If you're reading a stack of EKG, you will call this non-specific T abnormality. But in context, when you have evolving T waves that are biphasic or profound, this is concerning for ischemia. So that T wave here is not concerning for ischemia, but evolving biphasic T wave is concerning for ischemia. It would be particularly concerning if it had a Wellens shape. Wellens shape, the descent of that T wave will be very sharp, almost 90 degrees. So this is not a Wellens T wave. Nonetheless, it is biphasic, evolving in context, and that troponin is not easily explained. He has a primary chest pain presentation. So it is concerning. An EKG 10 minutes later shows even this, an accelerated idioventricular rhythm competing with a sinus rhythm. So now we're building even more ischemic findings. So we cath this patient urgently, and indeed, he had an occluded diagonal. You see his stump here. Occluded diagonal, and he also had severe LED disease. So we did stent both using a TAP 2-stent strategy. I want to give now another third major slide. So far, I've given two big slides that you need to print and carry with you when you're doing inpatient cardiology. This one, as well as this troponin classification. And this is the third major slide that you need to carry with you. This slide is focused on how to manage patients in the ED, particularly at the low troponin level, below MI cutoff, or in that low gray zone. Below MI cutoff, below this 1422 for troponin T, you have very low values that are either undetectable, less than 6, or detectable but with very low delta, less than 4 in absolute, or in this zone we use, if you use a relative value, we use 50%, but we tend to use absolute delta for this zone. So if you have undetectable troponin in that negative troponin, if you have undetectable, it's not just negative, it's undetectable or detectable, but very low delta at 2 hours, this patient can be discharged safely home with a very low risk of type 1 MI or death at 30 days. The risk of type 1 MI at 30 days is less than 0.5%, and the risk of cardiac death at 30 days is close to 0%. So, and that's the beauty of high sensitivity troponin, and the advantage is that it identifies within that negative zone a very low risk zone where you can discharge patients home. It's actually as safe, if not safer, to discharge those patients home with those troponin values than after a negative stress test. It has at least as strong of a negative predictive value for MI at 30 days as a negative stress test. Now, if your troponin comes into that gray zone, 14 to 52 or 14 to 100, and probably better to use in the US the 14 to 100. 14 to 52 works in Europe, European registries. 14 to 100 is what works better in American registries. So if your high sensitivity troponin is in that gray zone, or if your troponin is below MI cutoff, but you have a big delta over 50% or over 4, then those patients are in the intermediate zone, and those are placed in observation, and we repeat troponin in another 3 hours. If troponin remains in that gray zone, even if you have a significant delta, but you remain in that gray zone, then here you individualize. You may decide not to perform any testing, particularly if that patient already had CTA in the last 2 years or a stress test in the last year. Or you may decide to perform non-invasive testing, or you may decide to perform coronary angiogram. And if you decide coronary angiogram, it depends on the fact that this patient has delta and he has a context of type 1 MI. So for example, like those cases I showed, this one is troponin between 14 to 100, but it has a context of type 1 MI. So you may perform coronary angio here, depending on the context, and you need to have a positive delta over 20% to decide so. Now, if the troponin is over 52 or 100, this is the higher risk population. That doesn't mean you need cath, but you generally need admission. You need to decide, is it type 1 MI or type 2 MI or non-MI myocardial injury? Is there a type 2 mechanism, cardiac or non-cardiac major illness causing the troponin rise? And you may decide to do coronary angiography if delta is over 20% plus no concomitant acute illness to suggest type 2 MI or non-MI injury. Keep in mind that across population studies, troponin over 52 had only a 50 to 60% positive predictive value for type 1 MI. So even when you're in this zone, half the time you're not type 1 MI. You're either non-MI injury or you're type 2 MI. Particularly in the US, less than 50% of patients in this category end up having type 1 MI, more than 50% in European registries. And this is improved by using 100 rather than 52 cutoff. Another important idea with this algorithm, and I think if you print, you need to print that slide, is what we call significant delta. For the very low troponin values below MI cutoff, we use absolute delta 4 for troponin T, or a 50% in relative term based on a JAMA paper published in 2011. But above the injury cutoff, it's 20% that's considered significant delta. Sometimes with that gray zone, 20% is a little less specific. I would be happier with something in the realms of 20 to 50%. But nonetheless, if you want to pick a number, it's 20%. Now, if delta is in those zones is less than 20%, this is what we call a chronic non-MI myocardial injury. This one here, it's a chronic non-MI myocardial injury. And in those patients, ischemic workup is even less justified than even that gray zone, and definitely less than that. You overwhelmingly and most often, you do not need to do ischemic workup, but again, take into account the EKG and the context. That delta applies to all troponin assay, whether high sensitivity troponin T, high sensitivity troponin I, or the conventional troponin for hospital that still use the conventional troponin. So here are some ideas. Within the low high sensitivity troponin, very low values, whether undetectable or detectable with low delta, imply low risk and safe discharge with negative predictive value over 99.5% for type 1 MI and close to 0% risk of cardiac death at 30 days. Even the rule-in black zone, like I said, this zone only has a 50% positive predictive value for type 1 MI, maybe even less so in the US, and this is improved by using a higher cutoff in the US of 100. Importantly, and that's an important idea for me, clinical scores like heart, TIMI, and others do not improve the safety of this algorithm and unnecessarily reduce the proportion of patients ruled out. So confusing and complicating this algorithm by adding a heart score or other scores will lead to more admissions and more testing. They will lead to less patients ruled out because they have heart score because of their age or their chest pain description. And you'll end up with less discharges. And actually, there are 2 European studies, those 2 here, that have shown that adding heart score does not improve the safety of this algorithm. It's already safe with over 99% negative predictive value at 30 days without using the heart algorithm. There is this American study here that tried to spin the data and show that heart score improves negative predictive value by 1%. But in fact, the negative predictive value, even in that paper for death type 1 MI at 30 days, was not improved and was still less than 1% without the heart score. And using the heart score came at the cost of a massive decline of the rule out value. And these are some of the studies I used to derive that algorithm. And you can review more information regarding that rule out ED management in the 2022 ACC expert consensus pathway and the ESC guidelines. They have their algorithm. I made my own based on the data, and it's somewhat similar and compliant with the ESC and ACC guideline, except it's a little more detailed, and I take into account various cutoffs from various studies. And they use here, you see that 52 cutoff. Now, other important ideas regarding troponin. When does troponin rise after MI onset? When does troponin peak after MI onset? And how to diagnose a recurrent MI in a patient with elevated troponin? So troponin rises within 1 to 3 hours of MI onset. It may take up to 3 hours, but frequently it rises at 1 hour. It peaks at 24 hours in non-reperfused MI and stays elevated for 10 to 14 days. It peaks a little sooner in patients who had acute recanalization, especially in STEMI. So it would peak around 14 to 16 hours in recanalized acute STEMI. Otherwise, it peaks around 24 plus hours. So it starts to rise 1 to 3 hours, peaks at around 24 plus hours, and stays elevated 10 to 14 days. This is extremely important. This will give you two ideas here. In MI, the troponin will continue to rise until 24 plus hours after the initial event, even if ischemia of that initial event is alleviated. Troponin peak sees the past. The troponin that continues to rise does not mean you have ongoing ischemia. If the patient had chest pain at 8 this morning and at midnight his troponin continues to rise, it was 40 and now it's 500, that doesn't mean he's still having ongoing ischemia. If he's doing well and he's chest pain free, he had 2 hours of chest pain in the morning and he's no longer having chest pain, that doesn't mean he's having ongoing ischemia. You don't need to be alarmed by the fact that it's still rising in terms of he's having ongoing ischemia. You need to be alarmed if you had overlooked the initial diagnosis. If you dismissed his initial presentation, then yes, you need to be alarmed and adjust your treatment. If you weren't planning on cathing him, you need to cath him, not urgently because he's not having ongoing ischemia now, but you need to potentially change your strategy if you miss the initial diagnosis. But you don't think he's having ongoing ischemia. Very important. Troponin peak sees the past. The peak tells you how big the initial event was, not that it is still ongoing. That's one of the most common mistakes I see among fellows, and especially internists and residents. Now, another major idea that arises from that troponin kinetic is understanding that plateau. So after you peak, you get a slight and slow decline and a plateau over 7 to 14 days. And this is a zone where you don't get delta. That's about the only place where you don't get delta in MI within a few hours. So if you check troponin within a few hours in a patient coming 2-3 days after his MI, you may not have delta over 20%. You're on that plateau phase. On the plateau, you will get bumps. You know, troponin may go up a little bit, down a little bit, probably less than 20%. So you get that bumpy plateau. And that plateau is important, one, because you realize, you don't have delta in this. That doesn't mean you don't have an MI, you mean you're late. Two, it helps you time an MI, especially STEMI. STEMI, sometimes you need to figure out, is it less than 24 hours, more than 24 hours? If your troponin is at a plateau, it's not having much delta anymore, or if your troponin is declining, if you have a very high troponin that is declining or plateaued, that also tells you your presentation is over 24 hours. It's a late STEMI presentation in the case of STEMI where you're trying to time it. So that kinetics help you time MI, and that's another reason why it's important to understand. Now, how do you diagnose recurrent MI in somebody with a high troponin? It's a re-rise of a declining troponin of over 20%. Now, if the troponin is still on the rise, how do you diagnose recurrent MI? You do need that 20% further rise, but it's not enough because, again, the troponin will keep rising anyway because it's seeing the first event. So if he has another event here in the first 24 hours, how do you know it's a recurrent MI? Well, you need to rely on the clinical history in that case and the EKG. And the fact that it does need to rise more than 20%, but again, in this area here, it's not enough because it's going to rise anyway. Now, notice I've only described MI, and I said ACS is equal to type 1 MI. Now, what is unstable angina? I'll give you a case scenario. A 60-year-old man has a history of CABG 10 years prior. He presents with progressive exertional chest pain over the last few weeks. He gets chest pain walking to the bathroom, getting ready for bed, and sometimes in the middle of the night. It seems like a typical low-threshold angina. He's requiring nitroglycerin frequently. EKG shows non-specific T abnormality. His high sensitivity troponin is 9, and at 2 hours, it's 12. It's below the MI cutoff. What is the diagnosis here? ACS, severe stable CAD, or non-cardiac chest pain. And what's the management? Coronary angiogram, heparin plus coronary angiogram, or stress test. The diagnosis is actually B. In the era of high sensitivity troponin, a negative troponin makes a thrombotic or unstable process very unlikely. His symptom severity suggests severe and likely critical disease. But remember, critical disease does not mean unstable or thrombus because his troponin is negative. He may have had acute progression a few weeks or months ago. He may have had a plaque rupture a few months ago. And remember, stable CAD progression actually involves multiple layers of plaque ruptures. But the plaque is stable now, no thrombus, because his high sensitivity troponin is negative. So that's why in the current era of high sensitivity troponin, this patient should be called severe stable CAD. Now, you may still use the term unstable angina, but mechanistically, this is more severe stable CAD. And the importance of that is management. He definitely needs coronary angiography. He has severe low threshold angina. That's the best indication ever for coronary angiography. However, I would not give necessarily unfractionated heparin because it's unlikely to be an acute thrombotic process. Now, it's not wrong to give heparin, but anticoagulation therapy is proven useful for thrombotic process, MI process. It's not wrong to use heparin if you're suspecting critical disease, but that's not an established therapy for that specifically. What's established definitely is coronary angiogram. Here is more detail. In the current era of highly sensitive troponin assay, a true ACS with coronary thrombosis or resting pain is and must be accompanied by troponin rise. True ACS equal MI. Unstable angina is thus a vanishing entity. This is from my book. Like a lot of the statements I made in this talk are from my book, chapter 1. True resting angina of ACS will result in a troponin rise. So if you have resting true angina, you will have troponin rise. In case of serially negative high sensitivity troponin, resting pain is not angina. In general, chest pain in general is either non-cardiac pain, stable angina, sometimes severe, like in this patient, or true ACS with positive troponin. The negative troponin, truly unstable angina is rare and is more in the realm of severe or progressive stable angina than unstable CAD with acute plaque rupture. And Braunwald in 2013 already said that. As a consequence, unstable angina is likely to be further marginalized. Indeed, it's not clear that ACS events can occur without some increase in circulating troponin when measured by a high sensitivity assay. And patient with ischemic heart disease will again be divided into the original 2 rather than 3 major subgroups, the 2 being stable CAD or ACS-MI. So the term unstable angina may still be used for that patient, but the better terminology is severe stable CAD. And so you may still use that term stable angina for something like this, typical angina at mild exertion with a typical timing and duration of angina. Angina occurs with mild exertion, is relieved with rest, and lasts few minutes. Severe stable angina is a better nomenclature, and another term used in the guidelines, in the ESC guidelines, is low-risk ACS for those patients. Now, I've described the 4 types of major myocardial injury, and I've described unstable angina and the near death of that term. There is actually a 5th type of myocardial injury that I will describe briefly now and more so later on. This is what we call MINOCA. So you have patients who have a type 1 MI presentation. They present with chest pain, a primary cardiac ischemic presentation, and they have potentially an ischemic ECG. And in fact, a proportion have a STEMI on the EKG. And some of them have severe troponin rise even in the STEMI range. Yet you cath them and you see no significant CAD. Basically, you see no stenosis over 50%. This is what we call MINOCA, and it is, I classify it as the 5th type of myocardial injury, MI with non-obstructed coronary arteries. There are 4 big causes of MINOCA. You need to memorize those. The biggest one is that they did have a plaque rupture or thrombosis that recanalize spontaneously or with initial heparin aspirin therapy, or that is overlooked. Maybe it's in a branch and you overlooked it. So that's the biggest diagnosis: recanalized or overlooked plaque rupture thrombosis. The second big diagnosis is myocarditis. The third is coronary vasospasm. The fourth is Takotsubo. Those are the 4 biggest diagnoses. It could also be an overlooked type 2 MI mechanism like bad decompensated heart failure, malignant hypertension, or PE, but usually those will not cause severe troponin rise. If you have severe troponin rise in the really type 1 MI range or STEMI range, it's one of those usually. Okay? So MINOCA, about 5 to 10%, it's not uncommon, 5 to 10% of patients presenting with a picture of type 1 MI have normal or insignificant CAD, less than 50% obstructive. The picture is mostly a non-STEMI picture, but up to 1/3 of cases are STEMI in registries, and half of the patients have completely normal angiographic appearance of the coronary arteries, even if eventually OCT or IVUS do show plaque disruption, plaque erosion. MINOCA is seen in both men and women, not just women, but it's twice more likely among women presenting with type 1 MI picture. Among patients presenting with type 1 MI picture, MINOCA is 5 to 10% in men, 10 to 15% in women. I will move on to describe the other big topic, which is EKG. In order for EKG to diagnose non-STEMI and ischemia, these are the features. The most important one is dynamic ST depression. It has to be transient, dynamic on serial EKG with a morphology that is not secondary to LVH. Static ST depression is less concerning unless the patient is persistently in ischemia and is having persistent severe distress and ongoing non-STEMI, which is not usually the case in most non-STEMI. So what we call ischemic EKG is dynamic, evolving, or transient ST depression, not secondary to LVH. Now, deep T inversion can also be allude to non-STEMI, but for T inversion to imply ischemia and to be specific for ischemia, it has to be deep, more than one big box, more than 5 millimeters. And even when it's deep, it has to be evolving deep, not a static deep, an evolving deep T inversion or an evolving dynamic biphasic Wellens T wave in the precordial leads. And here is some illustration. In a patient with either LVH or left bundle branch block, you get opposite change, discordant ST and T inversion with a reverse checkmark morphology. That is not usually concerning for ischemia, although it may be, depending how profound it is, if it is disproportionate to the size of QRS. And what is disproportionate? There is, for ST elevation, 20 to 25% is considered disproportionate, meaning the ST elevation more than 20-25% the size of QRS. There is no such thing validated for ST depression, but probably in that range will worry me as well. Also, if it is profoundly dynamic, even with this morphology and in LVH left bundle branch block, I would worry about discordant ST depression. But otherwise, it's those morphologies that are consistent with ischemia. You have negative QRS and negative STT, so that we call the concordant changes. Or you have discordance between the ST and the T. So you have ST depression with an upright T. That's concerning for ischemia. Or you have ST elevation with a negative T. That's concerning for ischemia. It would be STEMI in the case of course, ST elevation with negative T. And this is the Wellens here morphology. Wellens morphology is the biphasic T with usually slight ST elevation less than a millimeter, but the ST segment, even though it's not pronouncedly elevated, it has that straight or upwardly curved morphology. Then you get almost a 90-degree drop in that T wave, and it becomes biphasic. This is the Wellens T, and the precordial leads is very concerning for proximal to mid LAD stenosis, acute stenosis. This is another form of Wellens, that one that you see here, which is the deep T inversion Wellens, where the T is not biphasic, but even if it's not biphasic, you still have a straight or convex upward ST segment that dives deep 90-degree into a T inversion. This is another form of Wellens, also very concerning for LAD stenosis. Then you have those deep T inversions here. Without a Wellens morphology, the ST is not upsloping or straight upward. So those are concerning for ischemia, but less so than Wellens, and they are concerning for ischemia only when they are more than 5 millimeter and evolving. They need to be changing to be concerning for ischemia, because there is an entity where you have a global T inversion that could be due to actually LVH. LVH can give you actually T morphology similar to that, or cardiomyopathy like hypertrophic cardiomyopathy, or it could be high catecholamine tone states such as severe acute illness or intracranial process. So those are less specific for ischemia, but they may be concerning for ischemia in the right context. This is an illustration of LVH. So this patient has pronounced LVH voltage. He has Cornell criteria. He has limb voltage for LVH, precordial voltage for LVH, and along with that, he has that reverse checkmark morphology. So this is LVH with secondary ST abnormality. It's not particularly worrisome for ischemia. And as I mentioned, LVH can give you that morphology of T inversion without much ST depression, as in this, that can mimic ischemia. But in the big scheme, this is LVH. Now, what can be more confusing in the ST depression of LVH may be slightly dynamic depending on the heart position and lead position. For example, if you move the leads, the limb leads from the hands to the torso, that QRS will be bigger and the ST depression will be more pronounced. If you make the patient lie on his left side, the ST and the QRS will be more pronounced in those leads because the heart is now shifting more towards those left lateral leads. The QRS will become bigger and the ST depression will become more pronounced. So you may have an illusion of ST, dynamic ST depression in LVH, but be careful. It has to be much more pronounced to call it dynamic in the setting of LVH. Also, with time, patients with uncontrolled hypertension can have a progression of LVH. They can have progression of QRS width from LVH, incomplete left bundle to left bundle, and they can have, along with that, progression of their secondary polarization abnormality. If you have this ST depression that he didn't have last year, that doesn't necessarily mean ischemia. It could be progression of LVH and severity of hypertensive cardiomyopathy with time. This is another EKG. Look at this ischemic. This is ischemic ST depression. One, you don't have LVH voltage criteria, but importantly, you also have concordant ST depression. Here, the QRS is down and you have ST depression. QRS is down and you have ST depression in the same direction. And even when QRS is up, ST depression is very pronounced compared to the QRS. It's more than that 20% or so, particularly if you look here, for example. You have ST depression of 3 millimeter, whereas the R wave is about 15 millimeters. So it's very pronounced. Also, you have that ST depression with an upright T, that discordance between ST and T, which also alludes to ischemia, as I showed here. And EKG is extremely important. Even though 20% of non-STEMI have an absolutely normal EKG and are cut by troponin, ischemic EKG is still extremely important because it increases the likelihood of type 1 MI versus type 2 MI, and it increases the likelihood of extensive higher risk multi-vessel CAD. Even within the same type 1 MI, having no ST depression or mild ST depression or limited ST depression versus more extensive one, it changes the prognosis. Okay, another very important idea is Q waves. Q waves are traditionally a result of ST elevation, transmural MI, whereas non-STEMI traditionally doesn't lead to Q wave, but there is an overlap. You may have non-STEMI that gives Q waves. And why is that? How to get Q waves in non-STEMI? One, it's a non-STEMI with a large subendocardial infarct. But two, and more importantly, the other possibility is that non-STEMI was in fact a subtle STEMI or a late STEMI that did not lead to clear ST elevation but led to Q waves, especially inferior or lateral subtle STEMI. Which brings me to this other extremely important topic that I discussed in the past and I want to discuss again. Some non-STEMI are actually subtle STEMI and STEMI equivalent. And these are features on the EKG that you need to know because they indicate that this patient is not non-STEMI, it's a STEMI, and you need to consider emergent primary PCI. Non-STEMI is treated via cath, but it's not emergent, the cath. It's at 24 hours, even 24 to 72 hours. But STEMI is emergent. So you need to know those features that will gear you toward STEMI, what we call subtle STEMI, or what one group in Minnesota calls occlusion MI, OMI. So those are the features. You have subtle ST elevation, so it's less than millimeter, but importantly, the morphology is consistent with STEMI rather than secondary ST elevation from LVH or left bundle branch block. So you have subtle ST elevation, sometimes with subtle or glaring reciprocal ST depression or T inversion that will indicate that that subtle ST elevation is actually a real injury, ST elevation injury. Or sometimes you have evolving Q waves, or sometimes you have a shrinking QRS. Before you get Q waves in ST elevation injury, you get a shrinking of that QRS. That area where the muscle is dying or getting stunned becomes electrically inert. And before you get Q waves, the R itself will shrink. It will shrink, and so much so that it approximates the size of the T wave or becomes smaller than the T wave. So any of those, along with subtle ST elevation with a morphology consistent with the STEMI, suggests a subtle STEMI. And I have, under my talks of ST elevation and STEMI part 3, illustrations of that. Another subtle STEMI or OMI is when you have ST depression that is maximal and predominant in leads V1 through V4. This indicates posterior MI. The another one is DeWinter hyperacute T wave. Those are the hyperacute T wave in the precordial leads. Normally, hyperacute T waves progress to ST elevation, but there is a group of patients, up to 2% of individuals with anterior MI, who never progress to ST elevation. They are stuck at the phase of upright hyperacute T waves with a little bit of actually ST depression that is upsloping. So this is what you call DeWinter. That's an STEMI equivalent. Then the fourth one is left bundle branch block or V pacing with a discordant ST elevation that is over 25% of the QRS or concordant ST elevation. So those are STEMI equivalent. This is another illustration of the DeWinter complex. You have those hyperacute tall T waves in the precordial leads with an upsloping ST depression. Be careful, distinguish DeWinter complex from Wellens, those biphasic or deep anterior T waves with coved ST segment. Wellens is a non-STEMI, whereas DeWinter is a STEMI equivalent. Now, why is ST elevation mild in those subtle STEMI, especially in that first group? Why is ST elevation mild? And here is the explanation. You know, it's mild compared to classic STEMI cases because usually there is some flow to that infarcted area. You usually have either spontaneous recanalization, I mean, you're left with 99% maybe TME2 flow, but you have some flow, or you have subtotal rather than total occlusion, or you have subacute occlusion with good collateral flow and ischemic preconditioning. So the occlusion could be complete, but it's subacute, so much so that you have good collateral flow and ischemic preconditioning. That's why the ST elevation is not pronounced. That's why the troponin may not rise to STEMI level. And that's why I think those patients may benefit from late PCI over 24 hours. And they are, in fact, on the overlap between STEMI and non-STEMI. And that's why I like for that subtle STEMI to be a separate group. I don't like it to be called STEMI. I don't like it to be called non-STEMI either. I like to treat those patients emergently as in STEMI, but they are a little different. They are on the overlap between STEMI and non-STEMI, so much so that if you cath them late and revascularize them late, I believe they still benefit from revascularization because they have some flow that attenuates that ST elevation and that often attenuates the troponin rise. Again, spontaneous canalization, subtotal rather than total occlusion, or subacute occlusion with good collateral flow, CC2 or grade 3 collaterals. Another possibility for the mild ST elevation, and that one is bad, is late STEMI. At a time when you have deep Q wave and when ST elevation has already started to resolve as part of the natural progression of STEMI EKG, your ST elevation will eventually attenuate and may resolve. This is a bad one where you have deep Q already and minimal R and ST, residual ST. Okay, that's another case of mild ST elevation and subtle STEMI, but this case is a late STEMI. The third possibility, those are, I think, are less common, is MI area not well seen by EKG, especially posterior and lateral wall, or the MI is small and not well seen by the EKG. And some people have performed 72 lead EKG to catch those small occlusive MI. But the more important explanation to me is those two. 15 to 20% of non-STEMI are due to acute coronary occlusion, frequently left circumflex or RCA occlusion, and maybe pathophysiologically STEMI equivalent or subtle STEMI. However, because they more commonly have some flow to the infarcted area compared to STEMI, they usually benefit from late PCI more than 24 hours. They are on the overlap between STEMI and non-STEMI. I will give you some case illustrations that complement my prior talk. So this is a 61-year-old female. She has ongoing chest pain and diaphoresis and nausea that started 1 hour previously. No cardiac history. This is her EKG. At first glance, it looks very unremarkable. You may even be read as normal. There are some mild abnormalities. You have Q waves in V1, V2, which can be normal, as I explained under my EKG talk. You have some other abnormalities. You have subtle inferior ST depression. You have subtle ST depression in lead 1. You have subtle ST elevation in lead V4, V5, and especially with shrinking QRS. T in lead V4 is the size of the QRS. So maybe you're having a shrinking QRS with a big T wave and subtle ST elevation, subtle ST depression, Q waves in V1, V2. So in context, I'm worried about this patient. When you worry, you need to do serial EKGs. Now, serial EKGs were done on this patient. They didn't evolve much. So sometimes serial EKG will show you something more glaring. Maybe that ST depression will become more pronounced. That ST elevation will be more pronounced. The QRS will shrink more. So those are things you look for. Or the T goes from big hyperacute to inverted. It didn't evolve on that patient. Yet, the EKG was concerning enough for subtle STEMI to us, and she was having ongoing distress that is unexplained. So we eventually cathed her somewhat urgently, and this is what we found. She did have an acute occlusion of the LAD. The LAD is occluded, and there is also 95% stenosis of a large diagonal. Now, the LAD, even though it's occluded, it has good grade 3 collateral, CC2 collateral from that diagonal. It had also great collaterals from the RCA. You can see here. are collaterals to the diagonal and to the LED from the RCA. And again, that explains probably why, even though it's a total LED occlusion, she did not have pronounced ST elevation. She's not subtotal, she's total, but she has probably subacute with good collateral flow. This is another case. This is a 41-year-old woman, smoker. She presents with near syncope. Now she has this EKG. She has Q waves in V1 through V3. She has ST elevation, clear ST elevation in V2, and more subtle in V3. And she has especially ST depression, inferior leads. So this is consistent with anterior MI. Now, the reason the ST elevation is subtle and mild, and it's only seen in V2 and mild in V3, you have profound Q waves. So the reason this is here a subtle STEMI is that unfortunately this is a late STEMI presentation, most likely. So when you see this EKG, you think two things. This EKG with deep Q and minimal residual ST and R may indicate either late STEMI presentation more than 24 hours, or wishfully an earlier presentation, but she spontaneously recanalized, plus or minus on top of pre-existing collaterals, in so much that ST attenuate. However, it's unlikely to be too early of a presentation as she has deep Q with minimal R. As I explained in prior talk, STEMI, Q waves do not mean you are late on your presentation, do not mean at all that you're not going to benefit from revascularization. Actually, the overwhelming majority of patients with Q waves will benefit from recanalization, and Q waves develop early on within 1 to few hours of MI. However, this particular pattern of deep Q wave with minimal residual R and ST is concerning for late presentation, that profound Q with minimal R and ST. Nonetheless, you take into account the timing as described by the patient, and I would still take her to the cath lab if her symptoms started less than 24 hours, with the hope that she's had some spontaneous recanalization that was the reason for attenuation of ST elevation. Here is a summary idea that I explained. To improve the diagnostic yield of the EKG, especially when the EKG has non-specific or subtle findings, in a patient with persistent typical angina and non-diagnostic EKG, record the EKG in lead V7, V9. ST elevation is seen in those leads in 80% of left circumflex occlusions, many of which are missed on the 12-lead EKG. So to diagnose left circumflex occlusive MI, posterior MI, you may either have that predominant ST depression in leads V1, V4, but that's only seen in 60 to 80% of posterior infarct. Or you may have ST elevation in the posterior leads V7, V9, and that is seen in 80% of posterior infarct. So they complement each other. You may see the ST depression anteriorly without posterior ST elevation, or posterior ST elevation without this one. They complement each other. Hence the importance of doing the posterior leads EKG. The problem with posterior leads EKG is that the posterior leads are far from the heart, and so the ST elevation that is significant in those V7, V9 leads is usually 0.5 millimeter. And another idea is repeat the EKG at least 10-15 minutes interval in a patient with persistent typical angina. Now, even without persistent pain, do at least one EKG several hours later, a few to several hours later, or next morning, even if the EKG during pain is non-specific or unrevealing. The idea is that you may get post-ischemic evolving T waves, like the Wellens T or the deep T inversion, or evolving Q wave, even if the initial EKG is unremarkable. Actually, the Wellens T wave are typically post-ischemic T wave. You don't usually see them during ischemia. You see them as post-ischemic. Hence the value of repeating the EKG at least once after resolution of chest pain, a few hours later or next morning. I want to comment on the ST elevation in AVR. So if you have diffuse ST depression in more than 6 lead with ST elevation in AVR and V1, this is not STEMI. It may indicate, and it's concerning for a high-risk non-STEMI with suggestion of left main and or 3-vessel CAD. ST elevation in AVR must be accompanied by ST depression in several other leads not just isolated ST elevation in AVR. So ST elevation AVR is not STEMI or subtle STEMI. Those are the subtle STEMI ones that I showed earlier, those big four ones, not ST elevation AVR. ST elevation AVR is at best a high-risk non-STEMI. And what it implies is the following. You're having diffuse myocardial ischemia, diffuse subendocardial ST depression in all of the heart, and you get opposite change ST elevation. And what are the leads that are opposite to the vector of overall heart ischemic injury? It's V1 and AVR that look away from the heart. Now, specifically, if ST elevation is higher in AVR than V1, particularly if it is higher than 1.5 millimeter, it's usually left main diffuse ischemia. If ST elevation is equal in V1 and AVR or higher in V1 than in AVR, it's usually proximal LAD or a three-vessel disease or the proximal LAD. So left main AVR higher than V1 or higher than 1.5 millimeter. The other one, usually V1 equal or higher than AVR. But keep in mind, for any of those, you need diffuse ST depression for ST elevation in AVR and V1 to be meaningful. But importantly, that pattern is not even always non-STEMI and CAD. It may simply be global ischemia from demand-supply mismatch. At least in my experience, half the time when you have that pattern of diffuse ST depression with ST elevation in AVR or V1, the reason is not CAD, is global ischemia from profound demand-supply mismatch, such as profound anemia, profound prolonged hypoxemia, profound hypotension of any sort, such as massive septic shock, and commonly transiently after cardiac arrest, even with no CAD. When you get an EKG in those first few minutes after cardiac arrest, you may see that transient diffuse ST depression with ST elevation in AVR. It may even be seen in severe hypokalemia. So secondary ischemia, those is at least as commonly the cause of this EKG versus primary ischemia. And there is this paper in American Journal of Medicine where they did acute cath on patient with ST elevation AVR, and they found that 10% had acute occlusion, so the majority didn't, and no left main or LAD occlusion in any case, and 60% of the patient had severe CAD, 40% had no CAD, and only 25% had three-vessel CAD. So again, it fits with what I described, that this pattern is not STEMI, it is high-risk non-STEMI, probably around half the time, and in the other half, maybe more than half, it is a global ischemia from profound demand-supply mismatch. And about a third of the patients in that series were post-cardiac arrest, which explains, the reason why a significant proportion did not have CAD. Now, do I take those patients to cath urgently? The decision to cath urgently in less than 2 hours depends on the depth of the ST depression and ST elevation in AVR. The higher the ST elevation in AR, the worse. More than 1.5 millimeter is particularly concerning. And the persistence of that ST. So the depth and the persistence, and the lack of context of massive demand-supply mismatch. Now, I'll move on to the initial ideas of treatment. What's the treatment of non-STEMI? There are 3 axes of treatment: initial invasive strategy, antithrombotic therapy, and anti-ischemic therapy. And those are only meant for type 1 MI. As I've explained earlier, anticoagulation is only for type 1 MI. Definitely not for non-MI myocardial injury, and usually not for type 2 MI either, even when you suspect type 2 MI with underlying CAD. And it's not for chest pain with troponin below MI cutoff, even if description consistent with the true severe progressive exertional angina that we may call unstable angina. You may use heparin for those patients, but it's not definitely proven or indicated. And I explained that in type 2 MI, antithrombotic therapy and coronary angiography are not warranted acutely and systematically. So I want to focus on type 1 MI treatment. And the first axis is initial invasive strategy, which used to be formerly called early invasive strategy. And what does it mean, that initial or early invasive strategy? It means that you perform diagnostic coronary angiogram and possible revascularization within 72 hours of presentation and within 24 hours in the highest risk subgroup. Know those timelines, 24 to 72 hours. Unlike STEMI, that initial or early invasive strategy does not equate with early PCI. So early invasive doesn't mean early revascularization. It rather equates with early angiogram for risk stratification and subsequent management by PCI, cabbage, or medical therapy according to the angiographic findings. It's an early intent to revascularize. And actually, in most studies of early invasive strategy and non-STEMI registries, patients eventually undergo PCI in about 60% of the cases, cabbage in about 15%, and no revascularization in about 25%. What are the trials that put early invasive strategy on the map? Really, as a cardiologist, you need to know those 3 landmark trials that changed the way we practice. You need to memorize those: FRISC-2, STEMI 18, and RITA-3. Those establish the benefit of an early invasive strategy within 3 to 5 days and showed that this strategy in non-STEMI reduces the combined endpoint of death and MI in comparison to an initial conservative strategy. Initial invasive strategy means early coronary angiogram. So in those studies, about 60% or so underwent PCI, 15% underwent cabbage, and about 25% underwent no revascularization in those studies specifically. And in those studies, the timeline wasn't 24 hours. In FRISC, it was up to 5 days. In RITA-3 was up to 3 days. And in TACTIS, it was up to 2 days. So the early or initial invasive strategy, as validated, is within that 3 to 5 days. And again, that early invasive strategy did not reduce death. It reduced the combined endpoint of death and MI by 5% at 30 days and 1 year. Mortality was not reduced in the initial publication of any of those trials. Mortality was reduced at 1 year follow-up in the overall FRISC-2 trial by 40% in relative term, more so in the highest risk subgroup, and at 5-year follow-up in the overall RITA-3 trial, but not in the original publication and 6-month follow-up. Now, those beneficial results were seen despite the narrow difference in revascularization. Again, it was angiogram versus no initial angiogram. A good proportion of the conservative patients eventually did undergo angiogram. So the benefit is likely more pronounced if you take patients who qualify for revascularization on the angiogram, and if you randomize those to revascularization versus no revascularization, you probably will see a more pronounced benefit. Nonetheless, that's how the trials are designed, and that's the pragmatic way of designing them. In TACTIS, 60% of patients in the initial invasive strategy versus 35% of patients in the initial conservative strategy received revascularization at 30 days, this difference becoming narrower over the course of 6 to 12 months. So if you choose only those who get revascularized versus no revascularization, if they qualify for it, the benefit is likely more pronounced. Now, another important idea. So I said, what's the timing? I said the timing of initial invasive strategy is within 3 days. Okay, and those studies use 3 to 5 days. So how to be more specific here? There are 2 major studies that compared less than 24 hours versus 24 hours to 5 days, TIMAX and VERDICT trials. And less than 24 hours did not reduce the rate of death MI in the overall group, but reduced it in the highest risk group with a GRACE risk score of over 140. It reduced MI in the highest risk GRACE score. So it's preferred to do the early invasive strategy within 24 hours of presentation in non-STEMI based on the ESC guidelines. They give it a class 2A recommendation, but a more delayed invasive strategy, 24 to 72 hours, is appropriate based on those old trials and based on those trials which did not show definite benefit of less than 24 hours. And a delayed early initial invasive strategy between 24 and 72 hours is definitely acceptable in those unstable angina, or what I call the severe progressive stable angina. Now, how about more urgent cath, less than 2 hours? So less than 2 hours is not beneficial on large scale, and 2 studies analyze that, abort and early trial. So there are studies for every timeline. For less than 24 hours, you have those 2. For less than 2 hours, you have those 2. And there was no benefit of less than 2 hours versus within 24 hours. However, less than 2 hours is selectively indicated in some cases, and you need to know those cases. Those are cases of non-STEMI that we cath urgently. So you have ST depression that looks ischemic, not LVH, that is recurrent or persistent, especially if it's also profound or extensive with ST elevation in V1 or AVR. So ischemic appearance, recurrent or persistent, and profound or extensive. As an extension of this EKG idea, I explained earlier when to urgently cath patients with diffuse ST depression and ST elevation in AVR. Those are not STEMI. And you cath them urgently mainly when the diffuse ST depression and the ST elevation in AVR are pronounced and persistent. The other condition is angina at rest, and that second condition here frequently coincides with the first one. Angina or at rest or minimal exertion that is refractory or recurrent despite the initial antithrombotic and ischemic therapy with objective evidence of ischemia, typically, like I said, with positive troponin. In order for angina at rest to be angina, you need to have positive troponin. Except occasionally in those first 1 to 2 hours, troponin may not have risen yet above injury cutoff. And there you make a clinical decision. His angina looks real. Troponin hasn't had time to rise. It's in the first 1 to 2 hours. I will take him to the cath lab. But typically, even in that case, you will have ischemic ST depression that is persistent and possibly profound. The third indication for urgent cath within the first 2 hours is shock or severe heart failure attributed to ischemia, and along with that, you still have ongoing profound ST depression. It's not enough for shock or heart failure to be attributed to ischemia to qualify for emergent cath. They must have ongoing ST elevation or profound ST depression to qualify for urgent cath. If they don't have ongoing ST elevation or deep ST depression, wait to stabilize the patient clinically and diurese before cath. And here I want to further discuss this combination of MI and acute heart failure in general. Whenever you have acute heart failure, you ask yourself 2 questions. Is MI the cause of heart failure, or is heart failure the cause of myocardial injury and troponin rise? And number 2, if MI is the cause of heart failure, when should I cath the patient? So in answer to the first question, most troponin elevations in acute heart failure are non-MI myocardial injury secondary to acute heart failure. They are not primary MI. If any of the following 3 conditions is present, then MI is presumed to be type 1 MI causing acute heart failure rather than resulting from it. And what are the 3 conditions that tell you have type 1 MI causing heart failure? 1, it's evolving or dynamic ischemic appearing ST abnormality. They can be transient, but you need to have ischemic ST abnormality. New Q waves or severe troponin rise, such as high sensitivity troponin T over 300, 400, and high sensitivity troponin I over 1,000 to 2,000 or so in that range. When you have any of those 3 conditions, you believe MI is causing acute heart failure and an invasive strategy is indicated and multi-vessel CAD is expected. Now, once you've determined that it's MI that's causing acute heart failure, when do you perform cardiac cath? Cath is done 1 to several days later, not emergently. You do it once proper diuresis is achieved. Earlier cath in the first few hours is destabilizing for the following 4 reasons. 1, supine positioning and increased preload. Number 2, contrast loading, which worsens heart failure, LVEDP, and may precipitate shock. 3, procedural sedation, which blunts the compensatory vasoconstriction and tachycardia of pre-shock. And 4, the ischemia that will happen during PCI, such as during balloon inflations, stent delivery, no reflow, guide ventricularization, and all this is less likely to be tolerated if LVEDP is high and blood pressure is borderline or low. So cath and especially PCI will precipitate a downhill course of shock and massive pulmonary edema. And that's why you save those until later after we stabilize the patient for 1 to several days. Only unstable heart failure patients, such as those with shock or massive pulmonary edema already requiring mechanical ventilation, who also have ongoing deep ST depression or ST elevation. The key word here is ongoing deep ST depression or ongoing ST elevation. Then those are treated with an immediate invasive strategy within 2 hours. Possibly also those patients with massive troponin rise, such as troponin T in the thousands, along with being unstable, those may be treated with an immediate invasive strategy within 2 hours. And this is a paper that supports delaying cath in heart failure if possible. In this Korean registry of non-STEMI with acute heart failure, cath within 2 hours was associated with higher mortality, partly because of selection bias. Sicker patients were cathed early in that paper, but also partly because of potential harm of very early PCI in acute heart failure patients. And this is from that paper. Although the guidelines recommend immediate coronary angiography within 2 hours in such patients, meaning acute heart failure with non-STEMI, it remains difficult to identify the optimal timing. Surprisingly, no robust evidence supports immediate coronary angiography in patients with non-STEMI complicated by acute heart failure. Most were excluded from previous large randomized controlled trials. It is possible that PCI per se triggers further myocardial depression. The poorer clinical outcomes in early PCI groups have been proposed to reflect further deterioration of heart function caused by ischemia reperfusion injury, no reflow that develops during PCI, and or acute kidney injury caused by contrast media and reduced heart function. And this is a statement from a JACC state-of-the-art review. Early timing of PCI in patients with non-STEMI and acute heart failure has not been associated with reduction in adverse clinical outcomes. Again, all those support the concept of trying to delay cath and PCI in acute heart failure unless there is ongoing profound ST depression along with hemodynamic instability. And even if you have cardiogenic shock that results from ischemic cardiomyopathy with severe left main, 3-vessel CAD, if you don't have ongoing type 1 MI, meaning you don't have persistent ongoing ST elevation or profound ST depression or massive troponin in the thousands, immediate PCI may not be required. Rather, diurese and optimize the patient before PCI to reduce the PCI risk, reduce the LVDP, and raise the blood pressure. This is based directly and indirectly on shock trials inclusion criteria, what they defined as MI causing shock. For example, the original shock trial took patients with ST elevation or Q-wave MI. The IABP shock and culprit shock and ECLS shock trials recruited STEMI, but they also recruited non-STEMI, and a third of the patients were non-STEMI, probably with significant ongoing ST depression, although this was not clearly stated in any of those papers. What they did highlight is that the mean high sensitivity troponin T was close to 3,000s with a lower limit of thousands. Therefore, I don't agree with the European guidelines for acute coronary syndrome stating that an immediate invasive strategy less than 2 hours is indicated in patients with acute heart failure secondary to MI or shock. I don't agree with less than 2 hours for acute heart failure or shock unless there is ongoing profound ST depression.